use that for the recording, or no?
No.
Not really, because it's not good. Okay. Well, thanks for coming again. And today we have the amazing Dr. Jeffrey Valota from Kaiser, thoracic surgeon. He's going to talk about epidemiology. But before we get started with Dr. Valota, just wanted to share kind of a few thoughts that, as I usually do before the class gets started. Had my chemotherapy on Thursday. Felt a little nauseous coming over. Unfortunately, ate some spaghetti with tomato sauce. Got more nauseous. So, this is kind of the life of a cancer patient. I know a lot of you are taking this class because you want to kind of see what a patient goes through. And now that a lot of this care has become more chronic and out of the hospital, like when I was a student, a lot of this was in the hospital, more acute care. And now a lot of chemotherapy is done at home, done periodically, and you have to really work to manage your symptoms at home. And everybody comes up with their own kind of method to manage their own symptoms. But really wanted to talk about today how important it is because, as you may recall, I co-founded the Center for Asian Health Research and Education 6 years ago with Dr. Latha Palaniappan. And I looked it up, one of the first talks was on screening for lung cancer in Asians who have never smoked. And one thing I've heard many times is my colleagues, Dr. Wakely and others, colleagues at UCSF, talked about when years ago they noticed how many Asian people were being diagnosed with lung cancer who have never smoked, and in particular Asian women. So I think the epidemiology is really crucially important to understand what's happening, how are the trends changing, and looking at how we look differently at never smokers and smokers. I can tell you, and I think Dr. Louie mentioned this study, but I'll relay it again. In Taiwan, there was a recent study in the spring which screened thousands of people with some sort of risk factor and people who had never smoked. And when they did these CTs on patients, about 2% of those people who had the screening CT ended up having lung cancer. So that's incredibly high. So if you do this screening test in smokers, at-risk smokers, 20-pack years plus, it's about 1% rate you're going to get. So the epidemiology, maybe it's changing, maybe it's not, but it's really important to understand this, especially from my perspective as an Asian patient and as a doctor who takes care of Asian patients who have lung cancer who've never smoked. So please join me in welcoming Dr. Valota.
All right. So I don't have the microphone, but can you hear me, Stephen? Okay. So thank you, Dr. Lin. It's and thank you guys for all showing up. It's a privilege and honor. I know that sounds cliche, but this is just amazing what Dr. Lin's able to do and share. Because what I'm going to go over here is a little bit about the epidemiology things, but also the cultural considerations of how Asians kind of maybe particularly think about cancer in general. And some of the barriers. So to have Dr. Lin really just tell you right off the bat, hey, I'm, EGFR, stage 4 and all that, that takes a lot of courage, especially in our population. So I'm really appreciative of Dr. Lin. All right, so I do have research funding. Okay, so before we get into, you've all heard Dr. Lin's story because this is, week 5 or week 6. The idea is, yes, we're going to talk specifically as we get into it with lung cancer in Asian Americans who do not smoke, but you also have to know the basics of lung cancer, and I think in how that trajectory has changed. I think it's important for whether you're an undergrad or you're a med student, and so we do have to talk about that. And then we'll go into a little bit about Asians who don't smoke and how we think it's a hidden disparity, despite you hearing from Dr. Lin that, yes, we've known about this for 20, 30, over that, 30 years, yet you're just hearing a little bit more so now. But it's been going on for a while. So I do think we have to, it's our time to speak up. All right, so yes, lung cancer, I'll go over these quickly because you guys are here to hear, I want to get to the discussion. But yes, lung cancer is still the second most common cancer. This has not changed. So med students, this is still on there. This has not changed in 40 years, right? It's the second most common cancer around. But the thing that you have to think about is, again, but it's the number one, so it's the most common, or second most common, but it's the number one cancer killer, and by double, right? So by double over prostate and breast, which, again, is important. It's not to belittle that, oh, we're in Breast Cancer Awareness Month, we're going into Lung Cancer Awareness Month in November. Those are important, but it's really lung cancer that people are dying of. So why aren't we talking more about lung cancer? And so part of that, there are stigmas associated with that that we'll get into. But bottom line is, in our field, me as a thoracic surgeon and whatnot, this is what we see day in and day out, and we wish that everybody hears and thinks about lung cancer all day, every day. All right. So yes, smoking and lung cancer, right? You still have to know this, right? You have to know that the most important risk factor for lung cancer is still smoking. It's not non-smoking still. And we think, I have to change this depending on what data you look at, but relatively in the United States, it's pretty much well known in the United States, about 20% of all lung cancers now is related to non-smoking. But the rest of it, right, is still related to either current smoking or prior smoking. And that if you smoke, it's still a 20-fold higher. Versus, I know what you guys are going to ask me next. Well, what about, everybody always asks, what about secondhand smoke? What about this and this? It's higher, but we don't know. We know the realm. We don't know in certain race ethnicities, like we think maybe Asians are more prone to that. But we think secondhand smoke is still only about 1.7 to 2.5 increase the risk. Versus smoking, if you smoke, it's still 20-fold higher, okay? And that we know age makes a difference, right? We know that if you don't smoke, that you may, and I'm going to show you some data, that you may be younger to get lung cancer, but in reality, the median age, the average age of lung cancer is 70, right? So it's very rare to get lung cancer at 20, 30, 40, which we're going to go over. You see it differently in non-smokers, but again, older age does make a difference, so just like other cancers. All right, so this is what I think is kind of interesting, and I tried to make it, I mean, obviously, I'm going to relate a lot to what Dr. Lin's story is, but I also wanted to relate to your population, to your generation. Of why, and we'll get into the vaping thing. This is pretty cool. But the idea is that there are other risk factors. So I talked to you about smoking, but yes, secondhand smoke. And again, I don't have enough time to go into all the details of it, but we think that certain race ethnicities, particularly women, may be even more at risk, more sensitive to secondhand smoke, to their DNA. We know previous radiation. What happens if you had Hodgkin's lymphoma as a little baby, and so nothing related to smoking, and you got radiated. We do see higher risk of lung cancer, occupational exposures. So yeah, a lot of us don't see arsenic, chromium, nickel, right, or even asbestos. But we do see it, actually, asbestos, as you know, mesothelioma, but it's a very common cause of lung cancer. So in people, in your grandparents or my parents or grandparents that were in the Navy shipyards, asbestos exposure can lead to lung cancer regardless of smoking. But the big one is, and I don't know if you can see that up there, but the big one is radon. That's actually, out of all of these like substances, radon is the most common cause of non-smoking lung cancer. And you're like, well, it's a byproduct uranium, it's in the soil, what can I do? You can't do anything about it. But what I will tell you a lot of people do now is they actually do get, and you can do when you buy your house, new or old, especially old, you can get a radon detector and see what it's at, because this just leaks from the soil. Just like and you don't have to live next to a power plant to have high radon levels. So radon it's an inert gas that you just can't smell or see or feel, but you do, but that's what a lot of people are doing now. And then we'll go over, so yes, increasing age. Male was kind of the classic risk factor for lung cancer related to smoking. That is now changing. All right, so we talked about, Dr. Lin wanted to talk about change. I'm going to show you data now that that's not changing, but that is still considered a risk indicator if you look at all the data. But what about family history? Sorry, FH, family history. Family history, I'm going to show you some data that family history, I think, is a real big deal. Acquired lung disease. People forget interstitial lung disease. For you med students out there, for medicine docs out there, ILD, autoimmune Sjogren's, rheumatoid arthritis lung disease has been shown to be affiliated with increased lung cancer regardless of smoking. COPD, just make regular plain old COPD regardless of smoking can do that. Right? And then lastly, people forget, and this we're talking about the Asian population, because we know in the Philippines and China and other East Asian countries, TB is very common. TB is a risk factor. In fact, to talk about Dr. Lin's study, the talent study in Taiwan, that was considered an additional risk factor. Because not only did they screen non-smokers, but you had to have at least one risk factor. And a high risk factor is actually a history of TB. And a lot of our patients do have a history of TB when non-smokers that are diagnosed with lung cancer. Okay. So I'm not an epidemiologist at all, but I started getting excited because I was like, these are all new things, right? But anyway, so vaping. Okay, so everybody always asks me about vaping and what they think about vaping, because I know about half of you, I bet, vape. I'm just kidding. I don't know. Probably not, but I think you do. I'm just kidding. So it came out mid-2000s, and everybody didn't know. Everybody knew that vaping, the big studies were that people were dying of vaping cannabis related to EVALI, which is kind of basically an associated lung injury, kind of like ARDS, related to the vitamin E that was heated up that caused an inflammatory reaction. 2,000 young kids died, right? That was a lung infection, or not infection, kind of like an ARDS, acute respiratory distress syndrome situation. So everybody was like, well, that's bad, that's bad. We know infection's higher with vaping, but lung cancer. So they looked at this, and these studies just came out, right? This is 2024, and then ATS, one of my colleagues, not my colleague, but he's a buddy of mine in South Korea that just presented this. And the idea is that vaping and smoking together have much higher risk. I already told you it's 20-fold higher in smoking. But then when you add vaping and you smoke, 80 times higher, okay? And they already know that. We just started vaping in the 2000s, but we already know that, right? Smoking has been around since whatever, for the dawn of time, right? We're already seeing it in vaping. So I urge you that vaping is gonna be a bigger problem if people, whether you vape nicotine or cannabis. And then lastly, this was a study out of South Korea. This is what I thought was really cool, was that smokers that quit, right? The whole idea behind vaping was to stop smoking cigarettes. Well, guess what? Say you quit smoking, and within 5 years, and they looked at this in the South Korean population, and that if you quit smoking and you didn't do anything, so kind of cold turkey or just did your Nicorette, versus if you quit smoking and you continue to vape, well, guess what? You had a higher chance of getting lung cancer and higher chance of lung cancer death if you continue to vape, even though you stopped smoking. And that was over just a 10-year period. So hopefully that'll freak you guys out. Anyways, you're fine. So 15 to 20% lung cancer in non-smokers now. That was never that number is actually real now, whereas before it was always like 85, 90% lung cancer is in smoking, but the new data, even on your test, they're not gonna tell you, they're not gonna let you say 20% of lung cancer is all non-smokers, but this is real new data, and this is really where we're at. All right, so why is this important? This graph should freak you guys out, and you guys should be thinking lung cancer when you go home. The top #1 cancer killer is lung cancer related to smoking. We know that, right? Or you guys, I already told you that, right? But look how many millions of people it affects. But when you include Asian countries and other East Asian countries, no longer is it 20% like it is in the United States, it goes to 30%. 30% of all lung cancer cases in the world is related to non-smoking. That should just alarm you. And it's the 5th most common cause of death, lung cancer in never smokers, okay? Look at that. That's the second line up there. Or not the second, but the 5th. So that should make you start thinking that this is a serious thing that we should all be doing what Dr. Lin's doing and educating. All right. So yes, I don't know. If any of you guys follow social media, maybe you've seen this picture a lot, but I think this was really to bring home the point that it's not always about breast cancer in women. But the idea is that I don't want you to concentrate as much on the picture anymore, but the picture does take home a lot of points. I do a lot of my research is in lung cancer and non-smokers, and we see a lot more in women than men, but we're going to go into both sides. But basically, more people die of lung cancer combined than breast, colon, and prostate. Combined, right? The overall 5-year survival for lung cancer, all stages, is 25%, versus if all stages, stage 1 through 4, breast, colon, prostate, it's pretty good in the 9th percentile. It's not to say that, oh, it's great you have stage 4 prostate cancer, but you can live a lot longer. And it's not that you say that you're not going to live longer as stage 4 lung cancer, but the data, statistically wise, stage 4 lung cancer is a lot more lethal. Yeah?
Why is the lung more susceptible to cancer than other body parts?
Okay, so, well, it's a couple things. The reason why you see so much of it, right, is that the smoking related, because the amount of smoking that people have done, it was a fad, right? 50s, 60s, 70s, across the world. And not only in the United States, but in other countries, it's like very common that 80% of the men smoke, right? So this just smoking related, that's why you're gonna have such a higher amount of lung cancer. And then what you're getting at is what are these other risk factors maybe causing it? Well, because like the air we breathe, right? It goes straight into your lungs, what you're breathing right now. And that's why we think living maybe in a certain area of China or cooking with a wok and not having good ventilation, you have a higher risk because it goes directly in versus say maybe your liver, right? It's kind of protected, right? It's kind of covered up, it's sterile. Our lungs are not sterile. Right now, what you and I are breathing in, we're more susceptible to things. So that's another reason why, if that makes sense. Good question though. So then I'm gonna give you another epidemiologic scary thing, right? I told you 20% in the United States, non-smokers. And then I said across the world, right? Because we had Asia, where we see a lot of lung cancer and never smokers in Asia. That's 30%. But then if I add this little caveat, right? How many people still currently smoke right now? Very little, right? Or if they do, it's closet smoke. You can't tell. It's 50% of all lung cancers in the United States when you count people that quit a long time ago but formerly smoked. So then you should start thinking the whole motto that a lot of us here, if you follow us on social media or whatever, anyone with lungs can get lung cancer. Then you should really be thinking smoking is not really lung cancer disease, it's just a lung disease. Or sorry, lung cancer is just a lung disease because the majority of the cancers that we're catching, they don't smoke. And do you guys know if California, let's talk about California too. So California, what's our rate of smoking of people that smoke in California? Are we like high, like a lot of people smoking, low? Do you guys know what we're ranked? It's low. Like how low? All right, so we're the second best. We have the second lowest smoking rate in the country. You know what's first? The lowest? This is not to be stereotypical or discriminative, but can you guess? It's Utah. It's a joke, but whatever. I have plenty of Mormon friends. So yes, we're very low, right? We're very low. 10% of all Californians, 40 million people in California, 10% document that they currently smoke. So we have a very low amount. Yet, I didn't show this slide because I'm getting excited now. But we have the second highest cancer deaths and the second most frequent diagnoses of lung cancer. Even though I told you that we are state number whatever, if you consider 51 states or whatever, 49. We're 49th with related to smoking, but we're number 2 for lung cancer death and number 2 for the most common in terms of getting lung cancer. So clearly, it's not all about smoking, right? Especially, yeah. They do have a role. So we do think that there's only one study that recently came out, and there was a study showing that people that were exposed more to wildfire did have more incidence of lung cancer, and that just came out like a year ago. So, and that was I think that was a Canadian study, because Canada, even though you think Santa Rosa and stuff, we had a lot of wildfires, it's actually Canada, Oregon, the Northwest that get a lot of that, and that's where that study came from. And so yes, you are at increased risk with that. Just like firefighters too, although there was a screen, well, we won't get into it, but you guys are, so we think firefighters have a higher risk too, right, because of the fires. But there was the data's not published yet, but Mass General did do a screening study for firefighters, and they didn't get a positive rate yet. But again, that may have just been a small amount. But we think it's so high that they're trying to do pilot studies in firefighters. All right, 25% for all stages, but we know that Asians have a very favorable prognosis, okay? And we've known that since this was published in Journal of Thoracic Oncology, one of the highest journals in 2009. We've known about this, right? All right, so we know it. So the idea is that you want to catch things early. 46% of all lung cancer, again, all lung cancer, we're still going through all lung cancer. I know I'll get to it because I know we got to go. But non-smoking and smoking is normally caught later. Okay, it's even caught more later if you don't smoke, but because there's no screening test per se. But the idea is you want to catch this earlier. And we're not catching it as early because this 5-year survival when you catch it late is 7% versus if you catch it earlier, 61%. Still not perfect. It's an aggressive disease, but it's something that we can do about. So what can we do about it? You got to know this. Now, this doesn't focus on, so this is not what Dr. Lin's not covered for. I may not be covered for this right now, but we do know we do have lung cancer screening, right? And lung cancer screening is based off of 2 trials that Dr. Lin talked to you about where they only found 1% and 0.9% of a lung cancer detection rate. But when they follow these patients out for several years, they had a greater than 20 to 30% mortality in lung cancer and a better stage from stage 4 to stage 1. And that was only diagnosing 1% in a smoking population. So we have lung cancer screening from 2014 on that's covered for everybody. If you are, I'm going to play this. This is a patient of mine because I'm also involved in our lung cancer screening. This is the lung cancer screening scan. All you need to know, it's 1 minute. It's low dose, okay? You're not going to get cancer from it. It's low dose. It's less than living in California for a year walking around the power plants. This is what all it is, no IV contrast, okay? But you have to get it every year. The whole idea is you don't just get the benefit from one CT scan. In actuality, 60% of the cancers on a lung cancer screening scan aren't found on the first one. You got to keep going back, just like you do for your blood test. So those are the criteria, but that's for the smoking population, okay? But that's just good for you guys should know that. All right, so the whole idea about lung cancer screening, the benefit is you want to catch it, you want to shift everybody from stage 4 to stage 1. And that's been shown with lung cancer screening. So done deal, right? You guys are settled on that, we know that, but that's just in that set population. All right, so how does it affect Asian Americans, right? We're here to talk, I'm Asian, Dr. Lin's Asian, we're trying to get a little bit of this cultural consideration. That's part of my talk. And even though lung cancer screening improved from 2010 to 2018, this was a study at Mass General. They do a lot of the lung cancer screening studies there. Alex Potter, who was actually a Berkeley student, didn't make a difference. Asians still got diagnosed more with stage 4. Partly, does that make sense? Probably, right? Because not as many Asians smoke, so they don't really qualify for as much lung cancer screening. Whereas the white patients, right, classically white, male, I'm not trying to be stereotypical, but the Marlboro Man, right, you got to think of it like that, right? They did go back. They're now diagnosed more with early stage than late stage. All those studies that you saw, they're mostly done in white males, okay? All right. So let's talk about us, Asian Americans, right? Disparities. So I think this is really important, right? So Asians are the fastest U.S. racial group. That's something to think about. Cancer, cancer, cancer. Cancer is the #1 cause of death in Asians. We are the only race, ethnicity, where it's not heart disease. And it's both for men and women, it's cancer. And I just told you lung cancer is the #1 cancer killer. So why don't we just funding lung cancer and all that? Well, part of the issues are, well, we won't get it. My grandparents were in the Japanese internment camp. We won't get into that. We're not talking about Chinatown and San Francisco and what they've done. So there's a little bit of racism, prejudice, but really what it is the model minority myth. And again, I'm not an epidemiologist. I'm a thoracic surgeon, but I deal a lot with the model minority myth, which is, I'll be very blunt and transparent, really, because I don't know if you guys know what that means. What it really is that not all Asians look like me, speak good English, drive a Tesla, and are doctors. Right? There's a very big mix of Asians from poor, high, all of the above. We're not all healthy. I don't all a lot of us can be very sick, but that's kind of the model minority myth. So you see all the NIH budget to Asian Americans, 0.17%. All the clinical trial participants, and this is not for lung cancer, this is just overall, right? It's nothing. And so she says this perfectly. I don't know her personally, but this is what I always like to say. That's why I always speak out and try it personal. Our problems never make the headlines. So that's your guys' job to bring that out to everybody else, not just me. All right, so I told you fastest growing racial group. But the thing that I think is cool about this, guys, is that I got mistaken too. It's Texas, it's North Dakota, it's South Dakota, it's Nebraska. That's where all the Asians are going. So yes, we have a ton of Asians where we are, but they're growing in this area. So not only that, we need to think about, this is a big deal. It's not just, oh, the West Coast state cares about Asians, right? It's going to be everywhere soon. So we should be studying this nationally. So the NIH should just be at my doorstep right now. All right. So the largest income spread. These are cool things, kind of just Asian things that you should know about. Out of all race, ethnicities, everything, Asians have the lowest income, Burmese, and the highest income, South Asian, Indian, right? So we have a huge mix. Our average is 75,000. So, but if you loop us all together, you just assume that we all make $100,000, that we're all very rich, and that we all aren't poor, and that we all, that's not true, right? It's a huge mix. So you gotta think about that. You guys maybe already know this. And this is the thing, this slide that blows everybody's mind away. So I hope you know, in the Bay Area, because we're talking the Bay Area, Asian Americans, all Asians, right? Not disaggregated, all Asians, we make up the majority of the population in the Bay Area, right? In Northern California, we're 33%. White, it's 32.9%. Okay, so this is our time, right? This is our time. You guys, this is not like just an Asian talk. I'm getting that you guys are firing me up, but it's not. But I think it's just something to think about. But we're also, look at the red dot on top. We are the largest group. Asian Americans are the largest group below the poverty line, and this is in San Francisco. And you guys know this. We're local. But imagine when I give this talk to Duke or whatever, they're like, "Oh, Asians? What? You guys are fine, right?" Go to San Francisco. And look, it's not all just what you think, right? You see, go to Chinatown, and you'll see what I mean. So you guys may understand this, but the rest of the country doesn't. All right, so lung cancer, disaggregated data. This is the only study to show it. I know we're not all the same, right? I'm in this room, we're all different, right? Asian subethnic groups. But even when you break it down, disaggregated data, which is like a hot epidemiologic topic, it's still the #1 cancer killer. Look at men. Every race, ethnicity, every racial subgroup, it's lung cancer, lung cancer, lung cancer. We're less likely to be diagnosed early, right? Partly because the smoking history is not there. The highest incidence is in the West Coast. Not surprisingly, we have the most Asians on the West Coast. But this is a West Coast issue. I mean, it's not a West Coast issue. But if we're not going to be bringing this issue up, luckily we have Dr. Lin to do that. But if we're not bringing this issue up, do you think they're going to bring this up in the Southeast? They're bringing up, and they have their own issues, right? Smoking related, like Kentucky, lung cancer screening. They don't see what we see. So we have to be saying something in the West Coast. But the good news, the survival is the highest. When we look at different, whether you want to call it race, ethnicity, structural determinants of health. Either way, when you break it down, Asians consistently, men and women, regardless of smoking, have better survival. So there's clearly other things going on, right? All right, so this is kind of the studies that'll hopefully bring it home that Lori Sakota, who is a true epidemiologist that I work with, I'm just kind of like the guy that speaks and talks about this stuff. But we published this recently, just 2 years ago. And look, the majority of lung cancer, this is lung cancer on all of Northern California. Again, if you're a Kaiser member, but we do own 45% of the market, so it's the majority of Northern Californians. Majority of lung cancer is women, and that's kind of what was kind of new to a lot of people, right? Lung cancer is now becoming more of a disease of women, actually. But we're going to get into some other things too, with regards to men too. But in reality, that's kind of what a lot of us have been researching over the last 7 or 10 years. Because out of the 15.5% that were all non-smokers, 3/4 of them were women. Still 25% are men, but 3/4 are women, okay? When you break it down, patients with lung cancer who do not smoke, they are more likely, we did all this logistic regression, they're more likely to be younger, less than 50. I want you to start thinking about people you know, right? And talking about Dr. Lin, Asian. Speak an Asian language. We couldn't break it down by what type of language, but speak an Asian language, being diagnosed with adenocarcinoma. These are all buzzwords. This is what you should be thinking if you're going into this field, but more likely to be diagnosed with stage 4 or luckily, incidentally, stage 1. And I'm going to bring you 2 examples here if we have enough, we'll have enough time, of 2 of my patients.
So I fill almost all of those except for the women.
I was just going to,
Not
that's
the
exactly,
female
so I've
part,
changed
yeah.
this, I'm trying to tailor it to Dr. Lin too, but that's exactly why. Usually I highlight the female too, because a lot of what I do is deal, but you're seeing very common things to what Dr. Lin has. That's why he's so brave, to like hear these kind of, these remember statistics as a talk, but also this is what he's living. So I commend his bravery. All right, so this is the big study, and they just quoted this. I don't know if you guys saw the CBS News, you know, with the other night, they just quoted this study. But basically, this was a paper published in Chest. We published this last year, and we wanted to look at incidence. Again, I'm not an epidemiologist, but incidence is very different than prevalence. Incidence you can measure by year. All race, ethnicity, smoking, non-smoking, lung cancer is going down. So everybody just thinks lung cancer is decreasing, and it is. So people kind of forget about it. The only race, ethnicity, and this is what I really want you to bring because this is Dr. Lin's course, the only one that's increasing in incidence, real time, 2% per year, which is AAPC, average annual percent change, is Asian American non-smokers. But this is the difference in our study that nobody else has been able to show. It's not just women, it's men too. It's just women make up more of that percent, but we're seeing it in men too. And that's what I'm going to show you today, which hopefully you'd be surprised by. I don't think you looked at my slides, but I kind of wanted to bring a different take. It's almost like a different disparity. Usually we think of it lung cancer in Asian women as the disparity, but in men actually, we do see it. And that's actually even more of a hidden disparity. But we need to start somewhere to get lung cancer never smokers. And right now, women we see more of, so we're trying to get that word out. But we see it in men too. All right. This is my patient.
At age 58, 5 years ago, I was diagnosed to have lung cancer due to EGFR mutation. I was totally asymptomatic at the time, no family history, I never smoked. And the lung lesion was picked up on a chest X-ray that I did for positive PPD. The final pathology revealed that the cancer has spread to the intestine, giving me a stage 3A diagnosis. I underwent lobectomy, radiation, chemotherapy, as well as oximetinib, a target therapy for 3 years, which I finished in end of 2023. In May of this year, I underwent surveillance, and the cancer has recurred and has spread to the spine and also the left adrenal gland. I was put back on a regimen consisting of targeted therapy as well as chemotherapeutic agents. I want to share this story with you to increase awareness. I was shocked by the experience. I was shocked not because I developed cancer. I was shocked because I never smoked. I'm totally asymptomatic, and I don't have any family history, and I'm diagnosed to have lung cancer. Thank you for your attention.
Thanks, Dan. So, yeah, so it's yeah, it's crazy when it's like, right, it brings it home when it's like a real, I mean, obviously you're seeing Dr. Lin in front of you, but this is happening. It just so happens that some of the that he's a doctor and he's a doctor. It's not just that, speaking of the model minority myth, it's not just Asian doctors that get this, but these are the ones that I tend to know, right? Or that will willing to speak out, because I'll tell you, the ones that aren't doctors, as part of the cultural considerations, they don't want to speak out. They won't put their name up there. I just called him like the other day and I said, hey, I'm doing this. This would be really cool. I think this is kind of different, you know, to show some Asian male, because that's what I see a lot of, but nobody really talks about that. They talk about Asian women in this field, but we see it in Asian male too. So I thought that was cool. And they were all willing to do this because they're like, we just need to get this out there. And he's had this for, 5 years. He's doing fine though. He's good. All right. So that brings my segue, EGFR. You guys did biochem, right? You guys know what EGFR is, right? Epidermal growth factor receptor. All you need to know, it's like a little protein in the cell, right? That's translocation, all that type of stuff. But that's what you hear. You hear buzzwords. Dr. Lin's already told you about his EGFR. Dr. Luong, you just saw, just talked about his EGFR. So we do see EGFR more in Asians, okay? Nearly double the amount in Asians than white, okay? Regardless of smoking, we see EGFR. So it's an EGFR mutation, but then what you're going to want to know is what's causing the EGFR mutation, which we'll go over a little bit. So you may say, that's just national studies, that's just like whatever, that's like the, but we looked at this. We want to look at our patients, right? This is you and me, right? If I polled half of you guys maybe, and I'm not speaking on behalf of Kaiser, I could care less what you are, but like you may be, right? Your family members may be in this study, right? Because we have such a huge population. That's what's nice about our database. So we looked over the last 7 years, and we looked broken down by race, ethnicity, and again, this was in women because we have much more women that are non-smokers that are Asian. But look, 2/3 of all the women that are diagnosed have EGFR compared to the white women, 22%. And I will tell you another area that we're noticing is Latin. We're seeing a lot more Latin too. But again, that's a different talk. That may be coming up down the pike. But anyways, EGFR, okay? So we see it even in our patients here. All right, so this is another one of my patients in a different story. He's a recent radiologist out of Kaiser San Francisco.
My lung cancer was detected instantly, right after fishbone. What happened was 3 months ago, I had persistent right neck pain for 10 days. I remember that I swallowed fishbone about 10 days ago. Since I'm a radiologist, I went to get neck x-ray to look for fishbone. My neuroradiology colleague looked at the x-ray and saw something, but wasn't sure if it's a fishbone or just some normal calcification. So she recommended neck CT. On neck CT, there was 1.5 centimeter nodule in the left lung apex, which was found to be adenocarcinoma on biopsy. 2 months ago, I was operated successfully by Dr. Valota, and I got back to work full-time 3 weeks ago. I think I'm just super lucky and blessed. The lung cancer was detected at early stage. By the way, in case if anybody was wondering what happened to the fishbone, actually there was no fishbone on the neck CT, and my neck pain went away right after I saw the nodule on the neck CT.
So these are buzzwords, right? I want you, because what I always tell students in a lecture, right? You're only going to remember 1 or 2 different things, right? All this hubbub that I'm giving you, if you can remember certain things, that's all that matters, just 1 or 2 things. You're not going to try to remember everything, right? You'll take notes for that, but you're going to remember. But you're hearing things, EGFR, adenocarcinoma, Asian non-smoker, diagnosed later or diagnosed incidentally, like at stage 1, okay? So all kind of things, these are like real world situations, right? And like I said, I just operated on him like, yeah, it's been about 2 months. Okay, so what's the cause, right? Yeah, wow, yes.
I just had a question.
Yeah.
About like, kind of the concept of exposure. I know a lot of people who have had like really severe lung issues, and they use maybe idioms of distress where they think they've like swallowed something, and that's like what prompts them to like go. To what extent do you feel like this is more prevalent in like specific populations to kind of articulate why they should go to the doctor, as opposed to like admitting? Does this make sense? Like as opposed to admitting that they don't feel well.
It does. You do see, again, you do see different cultures doing different things per se. Some that you can, and there's some data on that to show that certain in terms of anxiety levels and everything. What you're seeing here is that this is a little bit skewed. They happen to be Asian male non-smokers, but they also happen to be physicians that are following up that would follow up more, that are following up more than normal, than maybe what you may see in, again, try not to be discriminatory, but I don't know how to speak because I'm like a young kid, like discriminatory, like in Chinatown, somebody that has the same issue, that is kind of living in a poor, whatever, in a poor area in San Francisco. I don't think they, what we see at least in the patients, and because we see that they often have insurance, I don't necessarily think they're going to come in to get that looked at, to get an x-ray, or how would they know, right? He's thinking very, very abstractly, right? A fish bone, you can maybe see it on an x-ray because it's a bone, but how many of us are going to be thinking, oh, let's get that checked out? They're probably like, whatever, it's fine, right? And so yes, we may be catching, you're catching a skewed amount that luckily they came in for that, but it was not related at all. Like he's had that, but it's that he got checked out and got something incidentally, whereas a lot of people don't necessarily do that. And what we see in a lot of Asian cultures, and I didn't present this data, but we see as the reason a lot of them are diagnosed more at stage 4 is they've had symptoms for a long, long time, but they didn't think anything of it. And in the women's side, maybe different on the men's side, but on the women's side, we see a lot of the women say why they didn't come because they were taking care of the family. And this is in the United States. This isn't in California. This is not in Asia old school. There's like, we want to take care of the family. We got to do the kids. We're not worried about myself. And they keep coming back with cough, right? That's part of it. It's partly them, but it's also partly the providers. If you look back at all the notes and you talk to the providers, they're like, they kept on giving them Zofran. Or not Zofran, sorry, I was thinking Zofran. Prevacid. And then, so we think reflux first as a primary care doc. My wife is a primary care doc, so it's not like you think lung cancer right away, even if you're Asian female coming in with a cough. But it's the prolonged thing. They'd keep coming back, asthma medication, cough suppressants. They wouldn't get that imaging study. So that's what we're seeing. I hope that answered your question a little bit, maybe. All right. So what causes the EGFR? This is what we're trying to figure out. So we jumped on this study 3 years ago. It was started at UCSF. Heather Wakely obviously does it here, who you guys all know, UC Davis, Moon Chen. But the idea is lung cancer, and you got to study it in some population, right? So we're starting in Asian females because that's where you see it the most. So the female Asian never smoker study. So what's causing the EGFR? Well, this is what we're trying to figure out. And this is where we're at as of October 10th. And this is painful. This is where the cultural considerations come in, right? I'm 4th generation, so I don't understand it as well as some of my colleagues where they have their parents that don't speak English or they're 1st generation. So I'm 4th generation Japanese, so I'm mostly kind of Americanized. But I will tell you, we have a struggle. 600 patients? That should be easy to get. It's just a survey. It takes 30 minutes, and it's $75 gift card. We started this in 2021. Because this passive refusal rate. There's millions of cases out there, right? We know that. And it's all of California. And you have to be diagnosed. Right now, you can tell your family members, 21, you could be a control. 21 to 90, any Asian, non-smoker with no lung cancer, or you can be 21 to 90 and diagnosed within the last 18 months, any stage lung cancer, you would be this. We still have that many to go. And then we got to analyze it. So until then, until we get this and it's active out, the reason why I sound pissed off about this is because even when the patients that qualify, it's hard to get them to do it. They're like, I don't have time. I don't want to know. And there's the cultural blockade a little bit. I'm not going to get too into that because it'll get me too mad. But like I actually do a lot of the outreach. That's part of my job as a study. I'm like not the PI, I was kind of like the little lowly guy, but it's okay. I feel like I'm making a difference. But it's hard to enroll these people. So this is the website. Anyways, it's a 30-minute survey, saliva specimen to get your genetic ancestry. And if you have lung cancer, we already have, based on the California Cancer Registry, we already have your tumor specimen. So the patient doesn't have to do anything. It's a mail thing or online, and it's in different languages. It's in every single different Asian language. So why are they all saying no? There's other things. They're not all saying no. I'm just saying, just look at these passive refusal just means they don't answer the phone. So many people block their phone. So many people block their phone, right? And that's part of the issue. Something, yeah, I'm not saying it's their fault per se, but I'm just saying we have a, yeah.
Yeah, I do have a question. Going back a little bit, you just talked about since it seems to get in the way of diagnosing cancer. I'm a non-smoker with lung cancer. Like the neuroendocrine cancer, so a little bit different. But what I found in the system
Yeah.
And it wasn't until post-COVID, I got COVID, and it wouldn't clear that they did an X-ray, just a simple X-ray. And I look back at years of thinking, why did they never X-ray? Why did they never do a scan when I was in touch with my doctor so regularly? And I just wonder how common that is and how much, like, thinking it's asthma, acid reflux, allergies.
What your story is like 100% the majority. Like 99% of the time, that's what it is. Even now. That's why little by little we try to make aware so people think about this, right? But that's always what happens. And so what we're trying to provide is a certain time frame. So yeah, you get the asthma inhaler, whatever, albuterol, you get your I keep saying Zofran, sorry, the Prevacid. You get a little antibiotic, right? A little Z-Pack, whatever, all that stuff. Oh, it's COVID. But if you come back and you still have those issues, we're trying to tell the primary care providers, get a freaking X-ray at least at a minimum, right? At a minimum, although you can't see everything on an X-ray, right? You guys know that as med students, but at least an imaging study. That's the issue. They're way too late on the X-rays. The majority, especially of the women, they're caught way too late.
Why did women, we have a harder time advocating for ourselves when we're told that it's asthma and the work to persist to say, well, it's not asthma, the meds aren't helping.
Right. But it's also cultural misogyny, whatever you want to call it too, because if you look at a lot of the notes back, because I always check on this, right? Because the women are always like, why? You know what? I always wonder, was this really like, did you really just nothing show out of the blue stage 4? It's never out of the blue when it's the stage 4. And you look, and how many times, I shouldn't use the word misogyny. I don't know what I'm doing. Anxiety. It's fine. Anxiety, especially more in women. And there have been studies on that, right? I'm not a psychological person, but people look at that, and I definitely think that's a component too. Oh, she's just a crazy lady. She's like just stressed, you know? So I think that's a part of it, which is a problem. And so we're trying to say that you know, you need to have this on your radar now.
Just a time tick.
Good, I'm almost done. Perfect. All right, so we talked about the talent study. The only thing I really want to bring up the talent study that Dr. Lin was talking about is it was men and women non-smokers, okay? That's what's unique about this. And if you think men don't get it, look at the bottom slide. 26% were male. Only 26% were male out of the 12,000, but there was a 1.4% lung cancer detection rate, which we know is higher than the Nelson and NLC trial. So clearly, men actually in this situation, it's kind of crazy to say this, but because women we've been so focused on because people have been ignoring women, but men is actually even more of a hidden health disparity on top of that, okay? Just something to think about. And family history was the biggest risk factor. Family history was the biggest risk factor. You can see as high as 7% patients that had the lung cancer had a family history, and it goes significantly up if you have more sibling or first generation relatives. All right, so that's just to bring home, Dr. Lin already brought this point home. Talent, 2.1% versus the other two major trials, 1.1% and 0.9%. I'm not going to go over the female Asian never smoker study, but basically Elaine Shum at NYU, who was on that news article last night, has started screening women from the age of 40 to 74, and she has found 3 women out of 201 for a 1.5% detection rate, both with 2 with stage 2, 1 with stage 3, all EGFR that were caught. And this was just random, 40 to 74-year-old women, no risk factors, except being Asian and non-smokers. So it's coming down the pipeline. All right, so cancer, number 1 cause of death. Lung cancer is the number 1 cancer killer. The incidence is rising. What do we do in the meantime while we don't have lung cancer screening? You gotta be proactive about your health, just like you said. You keep doing it. Oh, yeah, I want asthma medication. Tell your family, yeah. No, tell your grandma, no, they need an imaging study. Get an imaging study, right? Start little. All right, yes, let your family know, promote research, blah, 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 the call to action type things. So this is what we're trying to do, right? This is public community awareness, and then get research funding on it. So I do have research funding on this type of stuff. So that's what you guys can do. We can join a study. Come get me and we'll apply for a grant. All right. Bryant, Dr. Lin is not one of my patients, but I got this off online last night. The other 2 on the side are my patients. This is more commonly what I see, but I try to tie it in a little bit, that it's not just Asian women, it's Asian men too. All right, that's it. I'm good. Thank you, guys.
So let me ask you, we got a couple minutes left. Well, actually, maybe 1 minute left. So we've got this talent study,
Yeah.
right? Not covered by insurance.
Yeah.
What should I tell my patients if they fit, say they're from Taiwan, they've got a family history or some other risk factor, they would fit what the talent study shows.
Correct.
Should I just order it and say, hey, you got to just pay out of pocket and get this test because I've got this huge study that shows it could potentially detect lung cancer in you? What do you think?
Yeah. So you got to pick your poison. That's why I said there's certain things when they look at the talent study and look at all the data. If they have a family history of lung cancer and they're Asian non-smoker, that is much higher risk. Where I would kind of focus them on pay for your CT scan. I will tell you, there's certain areas, even Redwood City has it, San Mateo has it, where they're doing. It's like these Asian clinics. They're doing lung scans because that's what they do in China right now. You go and get a free CT scan. They're using MRIs, which fine, but I guess because they're worried about the radiation, even though it's low dose. But they're getting those, so they're going to outside clinics to get it. But for your patient that comes into Stanford, or if my patient comes into Kaiser, I will order it for them. Kaiser, I can cover because I can indicate it, but I can't say it's for lung cancer screening. But if they fit that mold, meaning with a family history, those are the ones at highest risk. But if they just say, I do have women now come to me, and they'll say, oh, I'm an Asian woman, and I saw your talk, and can we get a scan? I say, that's probably overkill right now. I don't recommend it. If you want to, you can pay out of pocket and do it, but that's not what I recommend.
But if they have a family history.
Absolutely, family history. And if it's more than one in family history, 100%.
So
it exponentially goes up.
So what do we do? I mean, it takes so long to change the guidelines, if we can even do it.
Right.
USPSTF doesn't tend to like to make little guidelines for 6% of the population.
They hate it.
Right. So what do we do?
Right.
It's not covered.
Right. And yeah. So
like you said, the income disparity, some people can't afford to pay out of pocket.
So I didn't go into this, but we're actually I think Natalie Wu is going to do one too, but we're starting a screening study on certain so Asian women over the age of 50, non-smokers with a family history. And so what you have to do is, what the problem is it's in Taiwan that they did that study. Elaine Shum hasn't published her stuff yet, but she's doing it at NYU, and hers is too broad. They're not going to cover 40 to 74-year-old Asian women, right, to do that. So I wanted to be kind of proactive about it, thinking what insurance would cover, so I picked a high-risk group. So I'm going to pick 200 of them, and if we show results, I think that'll help. Oh, there he is. We heard about him. That's
Almost done.
No, that's him. That you have to show the studies here.
Yeah.
You have to show it in the United States, because a lot of people in the USPSTF and what they're saying is, that's Asia. Everybody's Asian there, so of course, it's not going to relate to the only 5% of 10% of Asian people here. So you got to do the studies here. It's very hard to get the funding for that, so we have to go think outside of the box, which is pharma. Pharma's funding my study. Right. So you have to show the studies here, and I will tell you, this is even more disheartening, is that there was a recent study that just came out, and we just I'll send it out on social media, but we just did a debate about this. Highly profiled pulmonologists in the American Thoracic Society just came out with a recent article that they're against screening this population because they think it's going to lead to overdiagnosis. So we have a fight on our hands, even with the clinicians out there that are publishing stuff, to not even do this this screening for this. So even more uphill battle. And I had a debate with them, but that's a problem when your doctors are saying that. So the USPSTF, they're not going to come knocking on this. So that's why I say right now, the slide before, be proactive about your health, because if you do have a little bit of cough, you have to just kind of motivate yourself.
Well, thank you so much.
Yep.
And a quick thanks to the class, just to harken back to your slide with the headlines. We did make the headlines. Our class was on the front page of the Mercury this past week, so we are changing that. We were front page news on the Mercury.
Yeah, it's amazing.
So thanks to all of you.
Thank you so much, class. Thanks for